Brain shifts, herniations, and coning are dire consequences of brain swelling and hematomas after traumatic brain injury. The cranial cavity is compartmentalized by dural partitions. There is a midline partition, the falx cerebri, and a horizontal partition, the tentorium cerebelli. These dural folds act as movement restraints. They limit brain excursions and distortion of the axonal bundles, which would happen if the brain were to spin inside the cranial cavity. The folds also act as fairly incompressible venous conduits. Intracranial pressure is a product of the volume of contents within a confined space, that is the rigid cranial chamber. The contents include brain parenchyma and interstitial fluid, circulating blood in the arteries, capillaries, and veins, and cerebrospinal fluid, both in and outside the ventricular system. There are three compartments within the cranial cavity: the midline falx and the horizontal tentorium partition the cranium into right and left supratentorial chambers and an infratentorial space which houses the brainstem and the cerebellum. Brain shifts occur when there is a disproportionate rise in pressure in one or two compartments. A brain shift becomes a herniation when there is vascular compromise, axonal bundle distortion, cranial nerve palsies, or CSF pathway block. Subfalcine herniation is also known as cingulate herniation. Here, the medialmost gyrus of the frontal lobe, the cingulate gyrus, shifts across the midline under the falcine edge. This shift can result in occlusion of the foramen of Monro, causing contralateral lateral ventricular dilatation. There is blockage of the anterior cerebral artery as it courses over the corpus callosum. This produces ischemia of the foot region of the inverted motor strip, resulting in contralateral monoparesis. Transtentorial herniation is also known as uncal herniation. Here, the uncus of the temporal lobe herniates between the tentorial edge and the midbrain crus. There is ipsilateral pupillary dilatation. The oculomotor nerve carries on its dorsolateral aspect parasympathetic innervation of the pupil, which arises from the Edinger-Westphal nucleus. The sympathetic supply of the pupil comes along the carotid artery, the ophthalmic artery, to the pupil. When the descending uncus presses upon the third nerve, the parasympathetic supply is occluded. Unopposed sympathetic action on the pupil results in ipsilateral pupillary dilatation. Contralateral hemiparesis occurs when axonal bundles of the corticospinal tract get distorted by the descending uncus. The posterior cerebral artery is the terminal branch of the basilar artery. The PCA supplies the occipital lobe. There is kinking of the occipital artery as it arches over the edge of the crus. This results in an ipsilateral occipital infarct. As the occipital cortex on one side is responsible for the contralateral visual field, there is contralateral hemianopsia. Foramen magnum herniations occur when the cerebellar tonsillar peg is pushed alongside the medulla, or rather the cervicomedullary junction at the foramen magnum. This can result in medullary compression and in lower cranial nerve syndromes. Descents occur when there is bilateral increase in supratentorial and later infratentorial pressures. Midbrain descents occur in a setting of bihemispheric swelling or bilateral hematomas. Midbrain compromise results in Taine-Stokes respiration. There are bilateral pupillary changes. Initially, there may be pupillary constriction, followed later by pupillary dilatation. Perforator compromise occurs with brainstem descent. This may result in direct hemorrhages. Medullary descent is usually a pre-terminal event. It occurs when pressure in the infratentorial compartment rises. The medulla, along with the cerebellar tonsils, gets impacted in the foramen magnum. This results in medullary failure. There is also perforator compromise. This is soon followed by death.